For me to introduce two of our next speakers. First is our very own Dr. Jim Wilson. We all know Jim very well for the last 2 years that he's presented to us some of the most amazing experiences over his career. As you all know, Dr. Wilson is a professor of medicine at the University of Pennsylvania. Guys, can you be quiet, please? Guys, quiet. You have all weekend to socialize. Let's get started. We have a long day ahead of us. Thank you. So Dr. Jim Wilson, he is a professor of medicine at the University of Pennsylvania. He's a pioneer in gene replacement therapy and has been working for decades on the development of adeno-associated virus gene delivery. We're very lucky that we have a program for Angelman Syndrome at the University of Pennsylvania GeneTherapy program, and he's going to update us on that program today. I'm also going to introduce Mr. John Crowley. John Crowley really doesn't need much of an introduction, and I don't want to steal his thunder because most of his talk is going to be introducing him to you. What's really phenomenal about John is that he's the parent. He's the parent of children who are affected by rare disease. And so he's going to speak to every one of your hearts what he did to make a difference for his children, which is exactly what we're all trying to do, is make a difference for our children. So I don't think I need to say much more because he's going to tell you his story, but his story was featured in books and movies and the Wall Street Journal and New York Times bestsellers. But John Crowley is a force to be reckoned with, and one day we may be able to stand on a pedestal near him to say that we cured our kids from Angelman syndrome. So, John.
Hi, Allison. Thank you for the very kind introduction. It really, really is an honor to be here this morning with every one of you. And what I'd like to do in the time I have this morning before I introduce and have Dr. Wilson come up and talk about the exciting work and the advances that he's had in the world of gene therapy that we're now blessed to be partnered with Jim and his team. But really what I wanted to do this morning is just to introduce myself, introduce our family, describe a little bit about what has been now a nearly 22-year journey for our family in the world of rare diseases, and to introduce to you my company, Amicus Therapeutics, and to describe not so much what we're doing. Jim will describe the research that we're partnered on, but to describe more of who we are and why we even put this company together. So if I can, I'll take you back to the day of our family's diagnosis. It was a Friday the 13th, March 13th, 1998, and we were told that our then 15-month-old daughter, Megan, had a rare form of muscular dystrophy known as Pompe Disease. And, up until about a year of age, Megan seemed like a pretty healthy child. But by a year or so of age, we realized, she wasn't pulling up on the crib, wasn't taking those first steps. Something wasn't quite right. And we went, I think, probably like many of you, from pediatrician to neurologist, from blood test in the case of Pompe disease to a deep muscle biopsy. And we got the news that day that Megan had this rare form of muscular dystrophy. And I remember asking the doctor, is it serious? And he said, yes, it's very serious. And he had never diagnosed a child with Pompe disease. And he had a textbook in front of him, very knowledgeable, very caring neurologist. And I'll never forget, his hands were shaking as he turned the pages reading the diagnosis to us and describing the disease. And at the end, he said most children diagnosed this early in life with Pompe didn't live to be 2 years old. We also had then with us our then 7-day-old son, Patrick. And the doctor turned to Eileen, my wife, and looked down at Patrick and said that there was a 25% chance that he had the disease and he needed to be tested as well. I asked, is there research? Is there any medicines, any treatment? And he simply said, no, I'm sorry, there's nothing that I know of. And go home, have Patrick tested, and enjoy the time you have. And I remember that long drive. We were living for about a year. I grew up in New Jersey. My dad was a cop in North Jersey, but we were living in California for a year after business school, and I remember that drive on that, cold, rainy day in San Francisco in the Bay Area. And I think in the course of that drive and getting home, I remember walking in the door, my mother-in-law had been watching Megan, and I couldn't even look at her. And, I think you go through in that first day, as I think many of you did, you go through a lot of emotions. You go through the shock, the grief, the denial, the anger. And for us, pretty quickly, we settled on determination. Determination, first to find out everything we could about this disease. I am not a doctor or a scientist. I spent quite a bit of time in the Navy and practiced law for a little bit and then got a business degree. But for us, this diagnosis, this wasn't something that was supposed to happen to us. This is something that happens to other people. And what I won't do is take you through the years after, but again, we went out and found researchers. And all I really wanted was to buy some time, frankly. At first it was, please, God, just let Megan get to her second birthday. And then she did. She got very sick very quickly and had to go on a ventilator within 6 months after her diagnosis. Patrick then, by a year of age, was on a ventilator, and all of a sudden our lives changed pretty profoundly. But we never had any meetings like this. I can tell you there were small little groups of families together in hotel rooms in North Carolina, in the Netherlands, trying to advance some research, and I got very frustrated. I think like some of you have in your past, with the pace of research, because we realized what we needed to do is to develop a medicine. In our case, the first therapy was an enzyme replacement therapy that would replace the defective or missing enzyme that Megan and Patrick and others like them, that's what was leading to the problem in their muscle cells. But I think for us too, it became a journey in life as much as anything, and we realized that maybe this, as much as it is a sprint, and for our children, their hearts were profoundly enlarged, and that's what they would have died from, cardiac failure. While their muscles were getting weaker, their breathing was being, significantly impaired. We went, again, through the world of research, finding scientists, frustrated with the pace of that research. We found one researcher at the University of Oklahoma who was a glycobiologist who had some ideas for technologies. No company wanted to pick it up, and so we took a home equity loan on our house and helped to start a tiny little company. And that company, eventually acquired by Genzyme, helped develop the first medicine for Pompe disease. It reversed the enlargement of our kids' hearts. Megan and Patrick became the 27th and 28th kids in a clinical study to receive that enzyme therapy, and it was really remarkable. This is a really tough business we're in. Science is really hard. Almost everything we try, it doesn't work, but hopefully it leads to some important learnings. So that medicine saved our kid's life. That was our first company, and that's what they made the movie on, and all the personal and professional challenges that go with that. But by 2005, I realized that first medicine for our kids was not a cure. It was a treatment. Made them stronger for a time in their muscles, particularly my daughter Megan, fixed their hearts, gave them time with us, time to live, better quality of life, and it gave us as entrepreneurs a chance to go back and think, what else could we do? And I think in that moment, we were so focused as a family on this race to a treatment, race to a cure, and then we finally had it. And we realized, it wasn't a cure. It was a life-saving therapy. But again, it gave us that time. And what it allowed me to do is to reflect and to think, what do I really want to do in life? And I decided that there's so much unmet need in this whole world of rare diseases that what I wanted to do is to start a company. And went out and found some early technology and some other diseases like Fabry disease, but also, focusing on Pompe again in those early days. Found some scientists, found some investors, and because we had success with that first company, we were able to raise some venture capital and professional money, and With that, we put together the company that I run today. We started this in 2005, and what I really wanted to do was to build a company that could be a lasting, enduring company. And while we would start with an early technology focused on that one disease, Fabry, we always had a really, really big vision. And what I ask everybody in our company, and we've grown from the 5 of us who started Amicus in 2005, we're now over 600 people. And we are headquartered in New Jersey. All of our science operations earlier this year, we moved to Philadelphia and built out our Science, Research, and Gene Therapy Center of Excellence on Market Street, just a couple of blocks from Jim Wilson. We're going to have about 75,000 square feet of laboratories now, all just opened in the last week or so, all focused on gene therapies. But let me just play a short video. I can talk more about Amicus and the company, but let me just play a short video that will describe in some of our employees' words what is Amicus all about as I introduce our company to the Angelman world. When we started the company, we decided the name would be Amicus Therapeutics. Amicus, the Latin for friend. We wanted this to be the most patient-centered and patient-focused company in all of biotechnology.
One of the most amazing things about being an Amicus is our ultimate patient-centric philosophy.
When we sit down every morning, regardless of what our role is at the company, we have to be focused on the patient and what's going to make a difference for them.
The approach that Amicus has taken with advocacy for the patient community definitely is something different than what has traditionally been done.
We developed the Patient Advisory Board program here at Amicus, and we did that because we knew that we needed the patient perspective in everything that we do.
We interact with these patients directly and really have a very unique understanding of what it is that the patients have to go through on a daily basis.
They get to know people. They get to understand our issues better by working so closely with people.
The Lunch and Learn program here at Amicus is something we've had, since we started the company. We invite people to come in that are living with rare diseases, whether they're a patient themselves or a family member, and we get to hear their unique perspective.
That gives the company the opportunity to have a face for the disease, to know what it's like to live with these conditions.
We were invited to visit Amicus Therapeutics to describe to the company what CDKL5 deficiency is, which I think is an amazing thing that they would want patients to describe a disorder to the company rather than academics or scientists.
It's pretty significant that a company will stop for an entire afternoon to learn about what's called a patient focus day. And the day we went, the disease focus for the day was my daughter, was Mia.
Through our interactions with patients, we have a sense of urgency. Time is the most precious resource if you're a patient.
It makes me feel good to know that there's a bunch of really smart people in the background working really hard to make our lives better.
For parents of a child with a rare disease, I think it's very important to have companies like Amicus. It is what provides hope to families such as ours.
This is a very unique company, I think, with that extraordinary focus on the lives, the spirit, the challenges of persons living with rare diseases. And ultimately, our duty as entrepreneurs in biotechnology is to develop the best medicines and get them to as many people living with rare diseases as quickly as we absolutely can. I'm asked a lot what makes Amicus different, and one way I describe it is I ask everybody at Amicus every day. We build this into our reviews, how are they judged in their annual performance, to think with every business decision they make, if you were somebody living with this disease, whatever it may be that we're working on, or you were the mom or a dad of a child with this disease, what decision would you make? How would you think about when is a drug safe enough? When does it look effective enough in animals? Which partners, which manufacturers would you work with? Which diseases would you be interested in? Where would you deploy your capital? Would you hire a person? We describe everybody at Amicus that they have to be passionate entrepreneurs. They have to want to live the mission. They have to want to do this for something bigger than themselves, bigger than the business, and they have to be ready to roll up their sleeves, work extraordinary hours, be those entrepreneurs. And so I'm very proud of the company that we've built, and you are blessed in the Angelman community to work with some extraordinary companies. I know Emil was here earlier and spoke with of Ultragenics. Emil was one of the very first doctors in 1998 who I went to see to help me with ideas in Pompe. You've got Ovid and Jeremy Levin is a dear friend as well. So in terms of, do we collaborate? We realize that the competition is the disease. And there may well be, many, many therapies developed over the years. And so, in that regard, we realize we truly are all in this fight together. And I think it's the mindset that we will bring at Amicus. What we try to do at Amicus, again, is to join the very best of science together with, what is really a pretty remarkable culture that I am very proud of at Amicus. And we've had some good success along the way. We've had many failures, but that's kind of the nature of what we do. And I thought I'd also share with you, for our kids, one of the questions I get when I have a chance to go out and speak about our family is, how are the kids today? So they took that first generation medicine. Megan and Patrick are now on a second experimental medicine that we've developed at Amicus, and it's further improved their lives. Still not a cure, but for Megan today, Megan in a week and a half will turn 23 years old. Patrick is 21 and will turn 22 in March. Thank you. It was interesting, Allison, when I saw your presentation about what's most important in this community. Number one is that ability to communicate, to speak. Pompe disease doesn't affect the mind, we don't believe. There's no evidence of lack of cognition, at least for many, many decades. But speaking, because of the muscle weakness, becomes a real challenge for these children. When my Megan turned 18, she joined our patient advisory board for Pompe disease. And they were helping us design our clinical study, and we were talking about 6-minute walk and forced vital capacity, all these technical measures of disease. And the microphone was going around the room, and they got to Megan and they asked her, what would be most important to you? And she said 2 things, and it was then hard to understand her, but she said, 1, if I could breathe without my ventilator for 1 minute, because Megan knew that is the most life-threatening aspect of her disease. God forbid something happens that, if a nurse or Eileen or I can't get to her, that would be pretty tough. And the second thing she said, though, was if I could speak more clearly. Because she was a senior in high school, and she said, if I can speak more clearly so that when I go to college in the fall, I could make more friends. So when you think about drug development, what's really important, we all want a cure tomorrow. We're going to get to a cure someday for all these diseases. I don't know when. But I can assure you in the field of Angelman, we've got a lot of great people working on it. We've had a lot of great people in our 20-plus years in Pompe disease. And what you find is rarely do you have that silver bullet. What you have are improvements, sometimes failures that you go back to the drawing board and you learn from, and you pivot in another direction. And you do have those fleeting moments of success where you do see improvements. You see the ability to speak a little more clearly, maybe to sleep a little bit better, maybe to have fewer seizures. Those are the steps on the path toward ultimately cures. I have one more video. It's only a minute and a half that I'll share with you that I think will bring, in a very real way, a lot of the lessons that we've learned and some of the great success Megan has had and the strength that she's brought in overcoming her challenges, and how through the advances in science she wasn't cured, but how she was made stronger. Oops, not that one.
Megan was 14 months old when she was diagnosed with Pompe disease.
We were told that she wouldn't live to be maybe 2 years old, so we were most focused on just getting past the next few days and months.
We have taught Megan that she is no different from anybody else. just because she can't walk or breathe on her own, that doesn't mean she can't do everything, just about anything anybody else can do.
She's gotten deeply involved in the Make-A-Wish Club, now the president of the Make-A-Wish Club.
The only way that a child could do this is to want to do it themselves.
When you think about the challenges that Megan lives with every day, we able-bodied people would look at that and think, oh my God, how does she do it? For Megan, I think she looks at it and thinks, how do you not do it? This is my life.
Megan is absolutely going to graduate. Megan's going to get a job. She's going to get married. She's going to have children. And she will tell you the exact same thing.
So, thank you. So what Megan said at the end of that video is, I just want to lead a happy, healthy life. And that's what we all, I think, want for our kids. And for us at Amicus, it's led us to this exciting world of gene therapy. I read my first paper on gene therapy in Pompe disease 21 years ago. And I called the doc and I introduced myself. I asked when was it going to be in the clinic. He said about a year. I said, great. It's 21 years later, and we are now just on the edge of bringing a gene therapy or multiple gene therapies into the clinic in Pompe. But for Amicus, 2 years ago, when I realized that the field was really advancing, we decided we had to be in gene therapy. We started by looking at over 1,000 diseases. We narrowed that down to 100 priority diseases, and then eventually 20 that we were most interested in, and Angelman is one of those. And that led us, I've known Jim Wilson for many, many years, and that led us to our early collaboration we announced just a year ago in Pompe, CDKL5, and Fabry disease. We had such success with combining our teams and technologies that Jim and I agreed that we really need to dramatically expand this collaboration, and we announced that back in May, which brought us now collaboration with Jim in over 50 rare disease programs, including Angelman. So this is one very important to us. I assure you that with Jim's leadership, as the science progresses, it's something our company would be deeply committed to. So again, it's been an honor. And now please let me introduce Jim Wilson, who you know, to talk about some of these exciting advances that Jim's had.
It's great to be back, to see all of you, and to have an opportunity to give you an update with the little time that I have, and what an incredible pleasure to be able to partner with John in a wide range of diseases, but in particular Angelman's. So I just want to give you a brief update on the progress of our research that has been funded by FAST up till now. Again, to provide some context for what we're doing and what you will hear from others, we're talking about replacing the normal version of the gene and delivering it to cells of the brain. And the way in which we do that is to use viruses, different types of viruses that you heard Allison talk about. But the virus I view as a Trojan horse in that it contains a payload, in this case a therapeutic payload, that when interacts with the cell delivers the payload and everything else goes away and all that is left is the gene. I've been working on this for 35 years to try to figure out how to simply do that. It sounds simple, it turned out to be a lot more complicated than I thought, but I reflected on a year ago when I was at this podium and what I was feeling, and a message that I had, which was, we're making progress, but are we at the point where I believe gene therapy is effective? And the answer is no. Are we at a point where I think gene therapy for Angelman would be safe? And the answer is no, but a lot of progress being made. So what about today? What are we feeling? Well, things have changed. It's been a good year. Probably not there yet, but the way we view the program that we've developed with FAST is gene therapy going to be effective? Possibly. And then if anyone's dogmatic about clinical research, I probably don't believe them, but possibly is about as aggressive as I'll probably be, a rather conservative person. But is gene therapy safe? And I think it's very likely going to be safe, so we've made progress. At the end, we'll share kind of what we're thinking about 2020. So why is this so hard? We have to encapsulate the normal gene, inject it, deliver it to the patient, and it has to get to the cells of the brain. So I've just tried to illustrate that as I sometimes try to think about it. I think about it, what would be the barriers to gaining access to a secret room in a castle? There are two general barriers. One would be a wall. You've got to get through the wall. And then once you're through or over the wall, there's a room that you've got to gain entrance to, and there's a special key. And these are two very different barriers. And in gene therapy, they prove to be two different barriers. So rather than an individual, we have our virus, which when developed for gene therapy, we'll call a vector. And the vector has to get across this barrier when injected into the blood. But this barrier is not a physical wall, but it's an anatomical wall. It's the blood-brain barrier that is impermeable to basically every large drug that we try to deliver to the patients. But once we get on the other side of that barrier, the remaining step is to open the door to the cell, which is via an interaction with a receptor. We've tried to overcome the barriers and try to open those doors, and that's what I want to share with you today. So how you deliver this this vector matters. We call it the route. What we aspire to, and I hope we'll get there, and I'm going to try real hard to get there, is to be able to inject this vector in the blood, overcoming the blood-brain barrier, and then delivering the gene to the neuron. Now, what's the state of the art? The very best AAV vector out there is something called AAV9. We discovered it at the turn of the century, and when we inject this vector into the blood of dogs that have a genetic disease, and we evaluate their tissues for gene transfer into the brain, the cortex or the cerebellum, or to the spinal cord, it doesn't look very good. It does not deliver genes to the brain, but actually the spinal cord. In fact, this vector was used to treat and potentially cure spinal muscular atrophy in the disease called Zolgensma because it has its root in the spinal cord. But we've taken a different approach. We've sort of tried to overcome through a route of delivery that blood-brain barrier by injecting the vector into the fluid, the cerebral spinal fluid, that Allison is chasing down from everyone in their samples. Directly inject the vector into that fluid, and it bathes the brain and would give some level of access. Not perfect, but possibly overcome that initial wall. And in the same dog model of this disease, when we did the experiment, it's, again, more color is better here, that we do get some level of gene transfer into the brain, the cortex and the cerebellum. It's not everything, but it is, I believe, we may be at a point where we can start asking questions about whether this is going to work. So what about Angelman syndrome? The question is, can we package the UBE3A gene in one of these vectors, AAV9, for example, and deliver it to a mouse model of the disease and correct the disease? So we and others have done this by injecting the vector directly into the brain of mice, and it's a lot easier to do this in a mouse, as Allison had suggested. In fact, you can even do it in a newborn mouse, and when you do that, if you analyze the brain of the mice, you can see in this particular gene that fluoresces, we've delivered a significant amount of this vector to the brain. So we can at least ask the question, if we get the gene in to this kind of model, would it benefit the animal? And when we do this with a vector with an AAV9-like capsid expressing a UBE3A, and we analyze the tissues, you can see all these brown spots. This is very efficient transfer and expression of the gene in the mouse. So now, if we can then deliver, will it work? And there are a lot of different ways to evaluate the impact of any therapeutic in this disease. And I'm just going to describe 3 of them and their tests, neurobehavioral tests. One is actually measuring body weight, and the other is ambulatory activity or rearing activity. So what is the performance of a normal mouse? This is a non-deficient mouse. That's in black. What about the affected mice? Those that are deficient in the gene and have the AS phenotype, that's in blue. Now the question is, when we give the vectors to the ones in blue, does it track with the untreated animals or with normal animals? So that's going to be in red. So red tracking with black is good here. That in all assays that we've evaluated, that in this type of model, we're able to correct the phenotype, which suggests that this has the potential to be effective in humans in 2 different assays. But translation is difficult, as Alice had indicated. Mice are not humans. But we focus a lot on leveraging that success in a way that would portend success in humans. And I want to just share with you what the challenges are. You've sort of gotten to know me. I'm pretty open about what the problems are, but I'm also pretty excited about some of the solutions. So what about getting genes into the brain of a primate? And we do most of our work in monkeys that have a brain that's a lot larger than a mouse, as you can indicate here. In fact, this isn't even drawn to scale. And so you can imagine that the delivery challenges in a very large organ are going to be much more significant than a small little pea-size organ, and indeed they are. And so even under the best of circumstances, when you inject the gene into the cerebral spinal fluid, and the best way that we can achieve this is not in the lumbar space, but into a space that's further closer to the head. Same space, same kind of procedure. We do achieve some level of gene transfer, as shown here in a monkey brain, where we're looking for brown spots. Now, if this was 100% successful, this would be all brown. And we think consistently, using this approach with our best vectors, we can get genes into about 10% of all the neurons in the relevant part of the brain. There is another part of the central nervous system, however, that is much more easily addressed by gene therapy using this route, and that's the spinal cord. Again, it's one of the reasons why spinal muscular atrophy was an initial success, where we can get genes into greater than 90% of the cells of the spinal cord, both the motor neurons and the sensory neurons. That is not going to be sufficient or probably useful in Angelman syndrome, but it did create a challenge for us. And if you look at that slide that says dorsal root ganglia, those are cell bodies that constitute all of the sensory nerves that leave our spinal cord. And we could get genes into all of them. We don't completely understand why. It's the most easily transferred cell of the body. So what are we left with? We're left with, at least in our hands, with enormous amount of experience, an approach that could effectively correct the gene in 10% of the cells of the brain. And the question is that enough? And I was quite skeptical last year that 10% would be enough, and Allison challenged me on that a few times, not only in terms of what she knew, but in terms of what we were doing. And I'll talk tomorrow about some gene editing work that we've done that does suggest that in the mouse model that 10-15% may be enough to show an effect. So I'm optimistic about that. But this highly efficient targeting of the dorsal root ganglia, these are these sensory cell bodies that are along the spinal cord that innervate really limbs and also muscles of the face as well, has created a problem. And this we've been talking about for a couple of years, and it's recently led to one of the clinical trials for spinal muscular atrophy to be put on clinical hold. So you're going to hear about this because it's important. It's important for you to understand. And it's something called the dorsal root ganglia. It's kind of a mouthful. But what it is these are the neurons that are outside, right along the spinal cord, that innervate the sensory neurons. And you can evaluate them by looking at the dorsal root ganglia, or you can look at them in terms of the projected axons along the spinal cord. And this is the way in a normal monkey, or presumably a normal human, they would look. But what we found a couple years ago in one of our early clinical trials of gene therapy, as we prepared for that there's evidence that the vector itself may cause some damage to those cells, as illustrated by those white ghosts or empty spaces on the upper panel, and then also some degeneration of those cells below. So we have studied this. We've seen it in 101 monkeys through 20 studies, independent of the vector, of the promoter, of the way you manufacture it. It's part and parcel of the approach for gene therapy. And now clinically, what would it cause? In its worst case, in monkeys, it causes problems with walking, which is ataxia. And you can't really ask the monkeys how they're feeling in terms of any potential pain, but it could cause pain, and this has surfaced in one patient with ALS. But I'm highly optimistic, so I'm really going on a limb here, that we're going to fix this pretty soon, and I'm pretty encouraged that we will, so that we will come forward with a vector system that, when applied to monkeys, will not have this problem and no other obvious problems, but will limit it by the gene transfer of 10%. And the question is that enough? And is that enough for us then to move into clinical trials? But as John had said, we're not done, and through the generous support of Amicus, provided us with $50 million of funding to improve delivery to the brain. And while this may be where we are now, I am sure with time this is going to improve. And I'll just give you an example of how funny biology can be. A different group from Caltech developed a version of our vector, AV9, that could deliver genes to the brain, the entire brain of mice, with just an IV infusion. It turned the brain green. What we found, though, is it was only unique to one strain of mice. Even another strain of mice, it didn't work, and didn't work in monkeys. So in science, that could be disappointment, and it was disappointment. But sometimes in science, you got to turn a lemon into lemonade, and serendipity is the basis of all true important discoveries, I believe. So we went on to try to determine why this one vector works so well. How did it get across the wall? And we were able to clone from the mice a particular receptor that's only found in mice, in this strain of mice, that's able to shuttle that vector very efficiently across the wall. And what we're now doing with the generous support of Amicus is we're trying to identify receptors very like this that are present in humans, so that at one point we envision an approach which we get broad gene transfer into the brain through an intravenous delivery. So where are we now? Possibly this would be effective. Is 10% enough? Is 15% enough? We may only know when we get into the clinic. But after I finish another set of experiments that are underway, I hope to be able to convince you that we can do this in a relatively safe way, realizing you'll never know that we get into the clinic, but eliminate that DRG toxicity. And then where are we going to be next year? I didn't want to go out on a limb, but I don't think that there are question marks, really. I think we're going to have the opportunity to sit down with all of you and stakeholders and say, is it time to go? If not, what more do we need to do? But I'm pretty optimistic that those conversations are going to go in a very positive direction. So again, I want to thank you again for being here for again another year, and I'm already looking forward to coming back next year to tell you what we're going to be doing, working with John Crowley and Allison and others. Thank you.
We'll just take a couple questions because we're running a bit behind.
And I'll be around for the rest of the day hanging out if you guys want to come up to me.